Okay, so now that the woman is dilated to 10, we're going to go to the second stage, which starts with the dilation, full dilation of the cervix, and ends with the birth of the baby. So we see those cardinal movements of labor that we talked about. So the baby has to turn. Contraction should be every 2 to 3 minutes, lasting 60 to 90 seconds. And at this point, the mother feels more in control because she can actually do something about the pain. She can push with contractions. She's focused on pushing, and it's not as stressful and anxiety-ridden as the first phase when she's in that transition and she's having those intense contractions. There's nothing that she can do about them. So this is an interesting point to make. In your ATI, it's kind of confusing sometimes because people can't differentiate between, students have a hard time differentiating, is the birth of the baby the beginning of stage 3 or the end of stage 2? And what it really is, it kind of, the birth of the baby takes you from stage 2 to stage 3. So it's kind of both, but if you kind of just think of it as like an arch that connects the two, that birth of the fetus, that is the arch that connects the second, it goes from the second stage to the third stage. That's helpful. And then that third stage of delivery, this should say third stage delivery of placenta. This takes about 5 to 30 minutes, says 2 to 30 minutes, and this is the separation of the placenta from the uterine wall and the expulsion of the placenta. So we know that the placenta has separated from the uterus, and we cannot, there's no pulling that on the placenta or anything like that, because we know that that can leave parts of the placenta behind and lead to postpartum hemorrhage. And the woman has to push the placenta out just like she did with the baby. So once we see these signs right here, then we know that the placenta has separated. So the uterus looks like it rises upward. Umbilical cord looks like it lengthens just because it's come out away from the uterine wall. And then you see a sudden trickle of blood released. And then uterus will retract to a more globular or round shape than it has elongated shape when the baby was in the uterus. So once this has happened, the placental separation, the mom can push the baby out, not the baby, but the placenta out. And then once the placenta's out, the nurses will do a firm uterine massage. It's called credaying the fundus. And we're doing that to get those blood vessels to constrict, minimizing blood loss. So these are really large blood vessels, these uterine blood vessels, and we need them to constrict. If the uterus is atonic or has no tone and is boggy, then she can have lots of bleeding and lead her into postpartum hemorrhage. So the placenta is expelled or delivered in 2 different ways. If you see the fetal side, it's a shiny gray side. You'll see lots of blood vessels in that shiny side, and that's called shiny Schultz. If you see the maternal side, it's this raw, almost like hamburger meat look. This is what has been attached to the uterus. So it has this red raw side. It's called Duncan, dirty Duncan. So those are the 2 ways that it can be delivered. Either you can see which part is coming out. Just know that there are 2 different sides. The fetal side, which is shiny, the maternal side looks like red hamburger meat, raw side. And in the lab you saw them. They can be quite big. Lots of women have them dried and put into pills, and then they can take them, and they say it helps with postpartum depression, or it can help with maternal healing and things like that. So it's just whatever people's belief systems are. And then the 4th stage, let's just say 4th stage, is the physiological adjustment, or this returning to normalcy. And this can be anywhere from 1 to 4 hours. There's lots of, you'll read this in your ATI, there's lots of care that the nurse needs to do. They need to be monitoring that baby pretty closely, the baby, yes, baby and mom both need to be monitored very closely during this initial postpartum period. This kind of sets in motion that postpartum period. Mother feels very peaceful, excited, and talkative, and it's this bonding. In fact, that first hour after a baby is born, we want to allow time for families to bond with baby, because baby is awake during this time, and we want to get them breastfeeding, doing skin to skin, doing as much as we can to help that attachment process. The mom will want to usually cuddle, breastfeed, look at the fingers and toes, and just kind of check out the baby. And dad will do the same thing, or the partner, if the partner is, a female or a male. Okay. And then the nursing interventions, and you will look at this in your ATI also, is you got to make sure that fundus is well contracted and firm. So if you see a boggy uterus, you're going to massage it to keep it firm. That's one of the main things. And you can see what happens here. You've got one hand with the bottom portion of the uterus, and then the top hand is sort of doing a massaging motion on that uterus to get that nice and contracted. You will see lochia. This is the vaginal discharge. It should be moderate at this point. Red, mixed with small clots, not large clots, very small clots, no larger than a quarter, and it should be moderate flow, like I said. If there's an episiotomy where they snip the vaginal opening to help the baby come out, you want to make sure that the edges are intact, they're approximated, and they're clean with no redness or edema. So there will be some redness due to the trauma of birth, but we don't want to see actual in the incision redness and edema. The tissue surrounding it will be. So that's something that students have a lot of questions usually about. The tissues, yes, will be red and edematous from the birthing process, but the incision should not be red. We want to encourage voiding still if the bladder will be hypotonic, and we want to make sure that she can void on her own. That's one of the main nursing considerations that we do. And we also get her up pretty soon afterwards. If she hasn't had a C-section, we get her up pretty soon to the bathroom and get her walking around and making sure that she can do that on her own. We're going to take vital signs often. You'll see that in your ATI assignment, or the assignment I have that you're going to look at your ATI chapter. And we're going to measure, we're going to weigh the amount of lochia, because we want to make sure that she's not bleeding too much. And we'll talk about the postpartum hemorrhage care that we do, and when we get them into the postpartum hemorrhaging, when they qualify for that, what things we do. I'll talk about that during postpartum lecture. So I have a vaginal birth video. This is an educational video. The best part about this video is the dad's face, and this is an unmedicated birth, so you can imagine that the woman is not quiet, but I posted that and you can watch that anytime, but I usually show it in class after this video. And I posted a video also about uterine contraction demonstration that you can watch also. We do that. It's with a balloon and a ping pong ball, and it's a really fun activity. It talks about the difference between Braxton Hicks contractions and true contractions, and how it dilates and effaces the cervix. And the balloon is a really great way to teach that, in class. But we can't do that here, so just watch the video. She's pretty entertaining, so it's only 3 minutes long. Okay, so we're going to start fetal heart monitoring because we have about 6 minutes left till this video has to be over. And this is, I would say, one of the most important parts about this class is the fetal heart rate monitor. We go over it in class, and there's a video in lab we go over it. And if you have not been to lab, please watch, it says maternal videos, please watch the fetal heart monitoring video, or you can review it if you have been to lab, either way. But this is demonstrating and kind of explaining what we do with the monitors, and we hook up the monitors to the patient. All right, so with low risk deliveries in patients, we can do intermittent fetal heart rate auscultation. This you won't see in the hospitals. In the hospitals, we do continuous monitoring. This would be more of a birthing center or a home birth. And women are untethered this way so they can move around during labor, and I will show you a water birth. The next video you can watch is the water birth, and you can watch the intermittent, the auscultation that goes on during that. And like I said, they're only for low risk labors. We're going to evaluate the fetal heart rate during that contraction so we know what's going on with the fetal heart rate. And we can do it in different ways. This is a fetoscope right here that she's using. And we're also going to get baseline. That's the first thing that we always do when monitoring fetal heart rate, is get the baseline fetal heart rate so we can see if there's good moderate variability and what the decels look like and accelerations and so on and so forth. We're going to do it more often so we start out less often in the latent phase, more often active phase. In transition and the second stage of delivery, we're going to do it very close together, make sure that fetus is safe. But this is what you will see in the hospitals. So this continuous fetal heart rate monitoring. So it's non-invasive, it's external. We do a fetal ultrasound on that upper fetal back. Remember, that displays the fetal heart rate, and then the tokomamometer that assesses the frequency and duration of those uterine contractions, and we place that on the uterine fundus. And we want to see the fetal heart rate in relation to the contractions. And so with this also, we get a baseline for about 10 minutes. And we want to see what that fetal heart rate is doing just on its own. And the normal fetal heart rate is 110 to 160 beats per minute. So if we're not getting a good reading externally, we can do internal fetal monitoring. And I think I showed most of you in lab that fetal electrode. It's just kind of looks like a corkscrew, and we kind of screw it into the fetal head. It's very superficial. It's almost the same as getting an IV in their scalps, and that's where we do neonatal IVs, is in their scalp. It's a really amazing place to do lots of things for babies. And this is an invasive procedure, so it requires that rupture membrane and must be dilated 2 to 3 centimeters. We can, along with the internal fetal monitoring, we can do internal contraction monitoring, and this is a intrauterine pressure catheter that measures the frequency, duration, and intensity this time, because we're going to measure the amniotic fluid pressure, so it's a really good reading. But these are both invasive, so we're going to do these only if it's necessary. And this is what the monitoring looks like. Like I said, we're going to take that baseline over 10 minutes. If we see bradycardia, anything below 110 for 10 minutes or longer, we're going to be very concerned with this fetal heart rate. Or tachycardia, anything greater than 160, 10 minutes or longer, we're going to be concerned with that. So here you see below, here are the contraction patterns. Usually we don't do mom's heart rate. We're going to do baby's heart rate, and we want to make sure it has really good variability. And you will learn all about this when you watch that video that Tara Haid has put together. This is a really great contraction pattern I have here for you. You can see that these are early decels, which are really great and normal, and it means that the baby is engaged or at zero station into that maternal pelvis. And we see lots of good variability, even some good accelerations in here. This is a variable decel caused by cord compression. So you can see that's a really good fetal heart rate pattern. So let's talk about variability. Variability are just fluctuations in that baseline fetal heart rate. We want to see moderate variability, like I said. So anywhere between 6 to 25 variation around baseline. These are considered, if you have no or small variability or minimal variability, this is considered non-reassuring, because we clinically don't know exactly what's happening. We just think that if these don't become more moderate, then there's maybe that the baby is not getting perfused. The baby can be sleeping, so we want to wake it up if we're concerned about it. So anything less than 5 beats per minute changed in that baseline fetal heart rate, we consider that non-reassuring. Moderate is 6 to 25, a well-oxygenated baby, and marked anything above, we know that that's non-reassuring as well. Okay, I'm going to come back to this. I got to stop this video now.